Hi everyone, this is Aurelie Najm from Glasgow. I'm delighted to be here with you for the second day of ACR, and today there was a lot of discussion about pre-RA, and the question really is, shall we treat or shall we not? And it was the topic of the great debate this morning, and I'm going to tell you a little bit about that. But also there are quite a few abstracts that's been presented yesterday and also today about, therapeutic intervention in pre-RA, especially pharmacological interventions. So basically, the first abstract that was presented yesterday is abstract 530. It was looking specifically into giving data of ARIAA. I think you probably heard of that trial. It's a randomized controlled trial of Abatacept in patients at risk of developing RA. These people had subclinical inflammation as defined by a positive MRI. And what they've had presented already at EULAR was what the onset of clinical RA was delayed, and these were the data at 18 months. And what was shown was that actually this again is delayed at 18 months. So fairly positive trial. And then we also had the two abstracts presented today, 1603, the treat earlier studies. It's a randomized controlled trial of Methotrexate in pre-RA, and it has been published in the Lancet. But basically the idea is if you give Methotrexate to patients at risk, again, these patients have subclinical inflammation confirmed on imaging, you are not delaying the onset of clinical RA. The patients that developed RA that were on Methotrexate, they had a milder disease, so to say, but yeah, it was not necessarily delayed. And the last one, which is abstract 1604, was StopRA. StopRA with hydroxychloroquine in patients at risk for RA. Again, population was a bit different this time because they not necessarily had any imaging showing subclinical inflammation. In fact, to be included, they just needed to have positive anti-CCP antibodies and no clinical inflammation. So the population was probably a bit more heterogeneous. However, the study, this randomized controlled trial, was actually terminated early, because interim analysis met the futility criteria. So it seems that hydroxychloroquine is also not efficient. So basically, what are we left with? Abatacept delaying, conventional synthetic DMARDs not really preventing anything. And there was this old study of, not old, but 2018 study of rituximab that was delaying disease onset for about a year. So at this stage, there are a few things to consider. Do we want to expose patients to the risk if the benefit is not necessarily the greatest, especially as we can't really prevent it? On top of it, the other consideration is, do we act at a stage that is already too late? Because people with at risk, with anti-CCP and subclinical inflammation, they have already a highly disrupted immune system. So maybe we should target patients in a much earlier state. Hopefully, this is the direction that next studies are going to take. So that was it for me today. Tune in on rubnow.com for more coverage, and see you around.